antimicrobial use and resistance module. So thanks everyone for listening in today, and thanks to Jackie and her team for inviting me to talk with you all this afternoon. So Jackie asked if I could provide an overview of the antimicrobial use, or AU, option within NHSN. For those of you that are not aware of NHSN, it stands for the National Healthcare Safety Network. I would guess that most of your facilities are already enrolled in NHSN to report healthcare-associated infection data to NHSN for your perhaps a state mandate or to participate in one of the CMS quality reporting programs. So kind of keep that in mind as we go through our presentation. There's likely someone in your facility, most likely in infection control, that has much greater understanding of NHSN and could tell you if you are in fact, if your facility is in fact enrolled and participating in other parts of NHSN. All right, I'm gonna put my screen in presentation mode here. Okay, can you just see the full slide?
Yes, we can.
Okay, great. Alrighty, so this slide just shows the NHSN structure. So there are quite a few components now that we have in the National Healthcare Safety Network. The AU option lives within the patient safety component and the AUR module. Like I said before, many of your facilities are probably already reporting to the device-associated module, which is where facilities report bloodstream infections, UTIs, perhaps ventilator-associated events, and the procedure-associated module, that's where the surgical site infections are reported. And the multi-drug resistant organism module, that's where the laboratory-identified MRSA and CDI events would be reported. So today, we're just going to talk about the antimicrobial use option, so that small piece of NHSN. First, an overview. So the AU option was released in 2011, so we've been around now for quite a few years. The purpose of the AU option is to provide facilities with a mechanism to report and analyze their usage data as part of their stewardship efforts at their facility. I do want to emphasize that all reporting into the AU option right now is completely voluntary, in that it is not required for any CMS quality reporting programs. It is included as one option for the public health registry reporting piece of the Promoting Interoperability program, which is formerly called Meaningful Use. So if your facilities participate in meaningful use, you could use reporting into both AU and the antimicrobial resistance option to meet one of the criteria for that program. There are a couple of states, Missouri is one, and Tennessee will be rolling out their requirement in this next calendar year, I believe, that require reporting of AU, and Missouri also does AR. So keep an eye out for your state requirements in the event that they may require reporting of these data as well. So who can participate in AU data submission? It's hospitals that have electronic medication administration records or the barcoding medication administration system. And that's just because we accept data from those administration systems only. So we do not accept pharmacy billing data or pharmacy orders, for example. It has to be from one of these two administration systems. And then for the denominators, for our AU option, we ask facilities to send those data from the ADP system. So the facilities that have those systems must also have the ability to collect and package the data using the standardized HL7 format of clinical document architecture. That's just to say that the data cannot be manually typed into NHSN. They have to be submitted in a standardized file format that we'll talk about a little bit later in the presentation. But for now, what you need to understand is the vast majority of facilities use a commercial software vendor to aggregate the data and package them in a way that they can be sent to NHSN. The list of self-reported vendors that are already submitting data for the AU option or that are interested in submitting data for the AU option is kept on the SIDP, the Society for Infectious Disease Pharmacist website at the link here on this slide. So I'd encourage you to check that out. You may already use one of those vendors, or if you're in search of a vendor, you may reference that list. However, it's also possible for what we call homegrown vendors. That's just the facility's internal IT or informatics resources to take this on. But we do not recommend that for the vast majority of facilities just because it is quite complex and does require quite a bit of time. So we do have those two options. However, we recommend in most cases for facilities to use a software vendor. We do have all sorts of facility types participating right now. So we have what we would consider our general acute care hospitals, which also includes critical access hospitals as well. But long-term acute care hospitals, rehab, oncology, and even psychiatric hospitals can all submit AU data into NHSN. So our numerator for the AU option is antimicrobial days, otherwise known as days of therapy. That's just the sum of days for which any amount of that agent was administered to the patient. Right now, we collect data on 91 different antimicrobials, which does include, the majority of those are antibacterials, but it also includes a handful of antifungals and anti-influenza agents. In addition to the total days of therapy for each of those individual agents, we also have facilities report the sub-stratified days of therapy by route of administration. Right now, we collect 4 different routes: IV, IM, digestive, which includes any drug that was administered into the digestive tract from oral administration through rectal administration. And then respiratory, or that's your inhaled antimicrobials. And like I said before, we only accept administration data from that EMR BCMA system, not pharmacy orders or billing data. So within the AU option, we consider 1 antimicrobial day per patient, drug, location, or patient care unit, and calendar day, regardless of how many administrations that patient receives. So if they have a drug that they receive twice a day, let's say they're on Cipro and they get that twice a day, that would still only count as 1 total Cipro day for that patient, even though they received that drug twice in that 1 calendar day. As I mentioned before, we get the total antimicrobial days as well as the substratified antimicrobial days by route. So to further break this down, you would have 1 antimicrobial day per patient, drug, route, patient care location, and calendar day. So let's say in that same scenario, my patient was on Cipro, and in the morning they got that Cipro dose via IV, but in the evening they got that Cipro dose orally. So they would still only attribute 1 total Cipro day, but they would attribute 1 Cipro day for IV and 1 Cipro day for oral. So when you're looking at your substratification of routes, that could, in many cases for drugs that are given more than once daily, the sum of the routes would be greater than the total because a single patient could attribute an antimicrobial day for more than 1 route in a given calendar day. The antimicrobial days are counted on the day of administration only. So even if perhaps it's an extended infusion or in settings of renal impairment, you would only count that drug on the day of administration. Alrighty, so for our denominators, we have 2. We use a denominator called days present, which is defined as the number of days in which the patient spent any amount of time in that specific patient care location or the facility. So that means that it is different from and not the same as patient days. So you all are probably quite familiar with patient days. It's a much more common denominator to use. However, for days present, we picked that so that we could have patients represented in both the numerator, the antimicrobial days, and the denominator. Since patient days is only captured once daily at the time of the once daily census count, patients have the ability to receive antimicrobials throughout the calendar day, obviously, and if they transfer locations, for example, if they started off in the ICU and then ended the day in the medical ward, we would want them in the denominator of both of those locations. So we'll cover an example of counting days present versus patient days on the next slide. But I did want to point out that they are different, and days present is used for AU data only. Patient days is actually used throughout the rest of NHSN. You do report days present for all of your individual patient care locations, as well as what we call FAC-wide in, which is basically the abbreviation for facility-wide inpatient, or all of your inpatient locations combined. And then our second denominator is simply admissions. So that's a little bit more straightforward. It's just the number of patients admitted to an inpatient location in your facility. So you would report admissions for the FAC-wide in record only. You would not submit admissions by individual location. Okay, so this table is going to help illustrate the difference in counting between days present and patient days. So for patient days count, let's assume a midnight census count. So for patient A, they were in the medical ward all day. So that's easy. They would get 1 day present for the medical ward, but they'd also get 1 patient day for the medical ward since they were in that location at the midnight count. Patient B is also easy. They were just in that 1 location all day. So again, just 1 day present for the medical ICU and 1 patient day for the medical ICU. So patient C is a little bit more tricky. So they started out the day in the medical ICU and then were transferred to the medical ward. In the days present column, you can see that they get 1 day present for each of those 2 locations since they were in that location at some point during that calendar day. But for patient days, you can see that they are only counted in the location where they're physically located during the census count. So since that's at midnight, they were in the medical ward at that time. So they would get 0 patient days attributed to the medical ICU and 1 patient day attributed to the medical ward. So here you would see is our first example of where the patient would be counted in the medical ICU for days present, but not counted in that units count for patient days since they were not there at the time of the midnight census count. And patient D moved around just a little bit more. They started the day in the ICU, then moved to the step down, and then finally ended the day in the ward. So for AU, they would get 1 day present for each of those locations since they were there at any time during the calendar day. But again, for the patient day count, they ended the day at midnight in the medical ward, so they only get 1 patient day for the medical ward. So again, you can see for 2 locations here for this patient D, they would attribute days present, but not patient days. So if I was totaling up my totals here for just these 4 patients, you can see that the days present counts are higher than the patient day counts for that same patient care location. And that's to be expected because, as we covered, days present, you're counted if you're in that location at any time during the calendar day. So for units that have a lot of transfer in and out, we expect the days present count to be a little bit higher than the patient day counts. But for units where there might be less transfer in and out, like ICUs, for example, it might be a little bit closer. Those 2 counts might be a little bit closer, but still we would expect the days present to be higher. Alrighty, so moving on, AU option, this is a very important point, is AU option data is submitted summary level only, okay? So when it gets to NHSN, it's already aggregated to the month level by patient care location, summarized. So we do not get any patient-level data since it's all aggregated before it comes to us. That means since we don't have patient-level data, we do not get dose, duration, or indication. So we don't actually know what the antimicrobials are being given for, or how many days they got the drug for, or the dose they got it for, or who prescribed the drug. It's all summed up just by the patient care location level. So those data are reported for all inpatient locations individually. So you would have one record for your ICU location, one record for your ward location, for example. Then you would have a record for all of your inpatient locations combined. So if I had 3 inpatient units, I would submit those 3 individually. Then I would combine them all into what we call our FAC-wide in or facility-wide inpatient. And we also collect data for 3 outpatient location types if the data are available electronically. So those are the emergency department, a pediatric emergency department, and a 24-hour observation unit. So if your facility did not have these location types, you would just not report them. That's totally acceptable. The next bullet, use the same mapped locations throughout the NHSN application, is a little bit less important for you all, but that's just to say that we would like the same patient care locations used for the HAI reporting to also be used for the AU reporting, just to make things a little bit more straightforward in NHSN. But again, that's a little bit more important to know once you're in the process of submitting. So keep that in mind for anyone that is in the process of submitting. And again, we would only want data from locations that can accurately electronically capture both the numerator and denominator from that given location. So in some cases, facilities are able to get denominator data from the ADT system for a given unit, but they're not able to get numerator data from an EMR BCMA system from that unit. So in that case, they would just not report that patient care location. That seems to be less common these days, but when we first rolled out back in 2011, through probably 2013 or 14, that was a little bit more common. So just something to keep in mind. Alrighty, so these next few slides cover how to submit the data into NHSN. So like I mentioned before, the data are submitted via CDA, or Clinical Document Architecture, as you can imagine, with 91 drugs and a total and a substratification for each of those drugs. It's just way too much data to be entering by hand. So we require that it be entered electronically to help in the accuracy and completeness of those data. So all you need to know really about CDA is the fact that it is a standardized format. So all facilities and vendors are following the exact same format when they're uploading their data into NHSN. I did include a screenshot here on the slide, and all I want to convey with the screenshot is the fact that this is a CDA file that is different from and not the same as a CSV or Excel file. We do not accept CSV files. It has to be a CDA file that uses the specific XML coding. So you can see that that takes, to put together this type of file, does take a deeper understanding of this specific type of coding, and not just any old IT person would be able to put this together for you. So we don't recommend taking this to your IT department and saying, hey, put this together for me. It's quite a bit more complicated than that, which is why we do recommend a vendor. But if your IT department is interested in learning more about this, or if you feel that you have the extra resources to take this on, we're happy to set up a call and talk further with you. So keep that in mind. Okay, so this slide just outlines the first 3 steps. So number 1, the EMR BCMA captures the drug administration when the drug is given to the patient. Then the vendor homegrown system extracts those data and aggregates those data elements, taking it from the numerator from the EMAR BCMA system and the denominator from the ADP system. Then the vendor packages those AU data into the CDA files. Remember, you would have one file per month per patient care location or unit. So we recommend uploading data within 30 days following the completion of the month, just to make that data, those data most actionable. So for example, let's say you were submitting, or you're collecting data for August of 2019, we would recommend just uploading those to NHSN within the month of September 2019, just to make sure those data are most current for your use. However, there's no rule in NHSN that requires that. And we do encourage historical reporting as well. So let's say it's August 2019 and you're working on implementation with a specific vendor, and you actually had data available to you back through January of 2019. That is totally accepted and definitely encouraged to go back and retrospectively submit data from January 2019 forward. If you happen to have data for even past calendar years, you can also upload those data. So we encourage submission of all historical data if available and accurate. So you would have one CDA file per location, per individual patient care unit, and then one CDA file for your FAC-wide-in. Each of those single CDA files contains both the numerator and the denominator for that given location, which is why you only have one per individual patient care unit. All of your CDA files can actually be uploaded within a single zip file, as long as it's beneath the maximum of 1,000 CDAs or the 2 MB size per zip file. But it would take you a lot of months of data, most likely, to get to that maximum. We do encourage reporting from all applicable inpatient and those select outpatient locations. A lot of times folks ask, well, can I just submit data only from my ICU locations? And the answer is yes, but we've found that it's actually a little bit more straightforward for vendors to just turn it on for all of your inpatient units, as opposed to picking and choosing which inpatient units you want to report. Now, again, it is up to you. It is voluntary at this time, so it depends. Whatever you want to submit, that's up to you. But again, we encourage complete submission to just make that most actionable by your facility. So for an example of our monthly data submission, remember I have one file per individual unit and one file for FAC-wide-in. So in my example here on this slide, I have a facility with 5 patient care locations. So I would have one CDA for my 1 North adult med-surg ICU, one CDA for my 1 South adult med-surg ward, one CDA for 2 North pediatric med-surg ward, one CDA for 2 South labor and delivery, one CDA for my emergency department, and one CDA for FAC-wide-in, which is the combination of all of my 4 inpatient locations above. So my med-surg ICU, med-surg ward, pediatric med-surg ward, and labor and delivery. So I would zip all of those CDA files up together in one zip file and upload them at one time. I do want to point out that you can submit multiple months of data in a single zip file. So in my scenario where you were just coming on board in this month, but you actually had retrospective data available to you back through January, you could in fact zip up January through August data and just upload that in one swoop. Okay, so I do want to point out that prior to uploading the data, you would add the specific patient care locations to what we call in NHSN the monthly reporting plan. So the monthly reporting plan just tells the NHSN application which data to expect from your facility. It has a lot larger role to play in the reporting of HAI data, specifically as it relates to those data that are shared with CMS for the publicly reported data. But for AU, all you need to know really is that you would list each of your individual inpatient locations as a separate row and have a row for FAC-wide-in and then any outpatient locations as well. then you would check the box in the antimicrobial use column. It is the same monthly reporting plan that's used for the HIR reporting, so there's just additional fields above and below this AUR module section. So in many cases, the infection control folks take charge of updating the monthly reporting plan, and instead the pharmacist or the stewardship folks are only in charge of uploading the data once the infection control people have updated the plan. So that is totally up to your facility. You can do it, you can work it out amongst yourselves, but if you have any questions about who does what or what sorts of user rights are required, we're happy to answer those questions as well. Okay, so there are actually two different ways to upload files into NHSN. So after you have them in your zip file, you can either do a manual upload as shown in the screenshot on the left, which is where you would log into your NHSN facility, you would browse for the file and then upload. Or you could use what we call an automatic upload from your vendor IT solution using direct CDA automation. So that's a little bit more complicated, and not all vendors offer that feature right now, but quite a few do. So if you are shopping for a vendor, that might be something that you want to ask them about. If they have that capability, that basically cuts out the need for you to log into your NHSN facility each month in order to upload the files, because you can just send the files directly out of your vendor system, and then they're sent similar to like a secure email, basically. They get to the NHSN servers and then uploaded that way. I do want to point out we have a great quick learn video. It's just a little over 12 minutes long. I have the link on this slide, and it covers kind of step-by-step the upload process to give you a better sense of how that happens. So I did want to point out just the steps of manual upload, since that's the most common, just to show you how simple that is. So from the NHSN navigation bar, that blue bar on the left, you would click Import Export. Then on the Import Export Data screen, there are two options. You would always pick the events, summary data, and procedure denominators, since AU are considered summary data. So then on the next screen, I would browse for my file. So before I get to this, I would have gone into my vendor system and exported or zipped up all of my files that I want to submit and save them somewhere on my machine or on the network. So I browse for them. Then I locate that zip file that I want to upload. Then that just puts that URL in that bar there, and I click Submit. Then NHSN does some validation just to make sure that the data are all formatted correctly in those files. So at the very top of this screenshot, you can see that I had summary data in my zip file. I had 8 records, and actually all 8 of them passed, so that's good for me. And then on the validation results table, the second table on the screenshot, you can see that all of my files were of the AU summary type. I had 2 months of data in my zip file, both September and October of 2016 for my locations there. The set ID is less important for you now. All you need to know about the set ID is basically it's the unique identifier for each of your CDA files. But probably the most important part of this table is the status column. So now you notice that in my status column, it says ready for import. So I did not have any errors associated with these files. So I'm ready. Basically, NHSN says, okay, go ahead and submit them now. So then I would click the gray submit button at the bottom to upload these data into NHSN. Once that's complete, I would get a little pop-up that says successfully imported my documents, and then I would want to click this show report button. That basically gives me a PDF of exactly what I submitted, and it tells me when I submitted it, and some information about those files. So when folks go about sending data via CDA, we always recommend that they open this report and ideally save it or take a screenshot of it, since this is basically your proof that you did upload your data at this specific time. And this is super helpful for us in troubleshooting. If you're having issues, if you say, hey, I uploaded my data, but I don't know where to find it, or I thought I uploaded my data, but maybe I had errors, this report is going to give us, on the NHSN team, the information that we need to help troubleshoot. Okay, so the complete data flow for y'all. So again, it starts off in the EMAR, BCMA, and ADT system. Then the vendor is going to aggregate those data into a monthly summary. Remember, no patient level data. They're going to have location-specific records and a record for FACWIDE in for all 91 of my drugs and my denominators. Those data are then going to be packaged into the CDA file format and uploaded into NHSN. Then as soon as they're uploaded into NHSN, you as the user are able to see those data via the NHSN analysis function. And if your facility is part of any groups within NHSN, so a lot of health departments have groups, some large corporations have groups, or quality improvement networks, pretty much there's all sorts of different kind of groups you can have in NHSN. Basically, that just allows other folks to see your data as well if you're wanting to share with them. And again, you can choose to not share with them. That's up to you. And then you as the stewards can compare internally, comparing months to each other or locations to each other, or externally by using our standardized antimicrobial administration ratios, or our SARS, which we'll cover in the next few slides. So first, I wanted to just cover quickly the steps for facility participation. So remember, I said the prereq for participation was that you have the EMAR BCMA system for your inpatient locations, at least. If you don't have this system for your inpatient locations, I would say you need to start there first. Then once you kind of get that up and running and validated, then you can start thinking about participating in the AU option. So the next step would be identify your facility lead or lead champions. That could definitely be all of you. Doesn't have to be one person. It can be a team of people. Then that team of people would go about gaining support. Obviously, you're going to need support from a pharmacy, but you're also going to want support from your C-suite people, your infection control people, since they are likely already in NHSN, already reporting other types of data, and also your IT folks. Even if you do use a commercial vendor, a lot of times your internal IT folks are needed to help, set up the correct data feeds, just kind of get things all hooked up as it's supposed to be. Then you would want to gather information on your current CDA submission capabilities. So, like I said before, some of you may already be using a vendor that has this capability available to you. So maybe you just need to turn it on, or get the next level or next version of whatever software you're using from that vendor. Or maybe you have to seek out a new vendor that specializes in sending the AU data. Or you could also be developing an internal system for doing the aggregating and packaging. Once you kind of get all those things up and running, then you would complete a validation, and then finally move into monthly submission and review of those data. Alrighty, so now I want to cover some of the NHSN analysis reports. So these reports are available to you immediately after uploading your data into NHSN. So there's no need to wait. You don't have to wait till the end of the month or any sort of time interval. You can generate these reports immediately after uploading your data. We have a lot of reports available for folks. We have some basic reports and some advanced reports available. We have different line lists, rate tables, pie charts, bar charts, and our standardized antimicrobial administration ratios, or our SARS. So first I wanted to cover the line list. So that generates just your basic list of each antimicrobial separated by location. So for each individual patient care location, I'm going to have 91 rows that shows my antimicrobial days and then my substratified routes of administration. It also shows the denominator, the days present. So you'll be able to see how many days present were reported for that given unit. For the rate tables, these all generate a rate of utilization per 1,000 days present or 100 admissions. Remember, admissions are reported for the FACWIDE in only. So we have rate tables that generate by antimicrobial category and antimicrobial class. So you can see in my screenshot here, it just shows the top of the rate table of antibacterials. I have one row for my all antibacterial rate, and then substratified into the different classes of antibacterials here. You can generate these by multiple different time periods. It defaults to show by month. We also have a rate table that allows you to pick the specific drugs you want to generate a rate for. So you can pick a single drug, as shown here in the screenshot. I've picked linezolid. You could pick multiple antimicrobials within the same class, or you could pick multiple antimicrobials within different classes. So this was at the request of our users. They wanted to be able to generate more granular rates, or rates that were more applicable to perhaps specific interventions they were doing, or specific types of presentations that they wanted to provide to their facility. Okay, so I wanted to spend the bulk of the time of analysis talking about the SARs, since those are potentially our most exciting output option available for the AR data. So what is a SAR? It's basically just the standardized risk-adjusted metric of antimicrobial use. For those of you that are familiar with the NHSN's SIR, or Standardized Infection Ratio, that's used for the HAI data, this is very similar. It does use an observed to predicted ratio. The SAR is available to all facilities reporting data into the AU option for specific location types. We'll cover those location types in a few more slides, but here you can see that the formula for the SAR is just simply the number of antimicrobial days observed, or that's what you've reported. That's your antimicrobial days or days of therapy, divided by the predicted antimicrobial days for that given category and location type. So the observed is just how many days your facility administered those specific group of agents to the patients in that location. And the predicted is calculated using our statistical models based on the nationally aggregated data. Okay, so SARs can be generated per month, quarter, half year, or cumulative time periods. They do default to show by month. The important part to know is that they're generated for very specific location types only. So for our 2017 baseline SARs, you could get SARs for data from January 2017 forward from data, or for data that were submitted from these specific location types. So under adult locations, we have the Med, Surg, and Med-Surg ICU, the Med, Surg, and Med-Surg ward, the general hematology oncology ward, and the adult step-down unit. You could get SARs from the pediatric locations, Med and Med-Surg ICU, Med, Surg, and Med-Surg ward. So that just goes to say that if you are reporting data from a unit that is not mapped as one of these location types, so let's say you have a specialty orthopedic ward, for example, that is not on this list, so you cannot generate a SAR for that location type. And these location types are basically those that we had the most data for, that we felt confident in what we're calling the national aggregate to be able to generate our SAR models. So that's not to say we won't have a SAR in the future for orthopedic wards or other specialty care locations, but for this time period, for this point in time, the SARs are available for these location types only. Okay, so this is what the SAR report looks like. I'm just going to quickly cover a few of the columns here. So we have the antimicrobial days column. That's my reported use. The antimicrobial, or the predicted antimicrobial days column, that's my predicted use. And those two columns are used to calculate the SAR value. So in my next few slides, I'm going to cover how to read this report. So the title of my report here is called Broad Spectrum Antimicrobial Agents Predominantly Used for Hospital Onset Infections in Adult SAR Wards. Okay, so that's just telling me what SAR category this is. So this is my broad spectrum agents predominantly used for hospital onset infections. And I do want to point out that because we don't have patient level data, we do not actually know what these drugs are being used for, but we've tried to group them in a way that what they're most commonly used for, or predominantly used for. You can find which drugs are included in each of our SAR categories in our AUR module protocol. I have that link later on in the presentation, so you can refer to that. But what you need to know basically is each of the categories includes anywhere from, I want to say, 7 to 15 drugs in the SAR category. So it's not just a single drug being used. And also wanted to point out that this table is showing me my adult SAR wards only. So I have 3 rows in this table. The top row is for my medical surgical ward. The middle row is for my surgical ward, and my third row is for my adult ward. If I didn't have data reported for all 3 of these different ward types, I would have fewer rows in my table. I could generate this exact same table for my adult SAR ICUs, or my step down, or my general HEMONC ward, anything that you saw on the other slide with the location types available. Okay, so getting to the red box. So this location, 5G North, reported 158 total antimicrobial days in this SAR category, the BSHO, or broad spectrum hospital onset category. Based on the SAR model, there were only 62.248 antimicrobial days that were predicted in this SAR category for this location. So that means that my SAR for this specific location is 158 reported antimicrobial days divided by 62.248 predicted antimicrobial days, which gets me a SAR of 2.538. So this is telling me that I have used more antimicrobials of this specific type in this unit, in this month, than were predicted by the risk adjustment factors and the national aggregate. So if I look at the last 2 columns, the SAR p-value and the SAR 95% confidence interval, based on these values, the p-value of 0.000 and the 95% confidence interval, the SAR is statistically different than 1. So this is telling me that my SAR of 2.538 is statistically different than the value of a SAR of 1. Okay, so that was a very, very quick overview of the SAR. There's a lot more to talk about with the SAR, obviously, but we just didn't have time available to us today, but there are additional resources that I'll point out in a few slides. But I did want to point out that the screenshots I showed today, a lot of them were the default the default analysis report. So that's just kind of, you click the report and then you click run and you make no other clicks. But if you want to modify the report to see potentially a specific month, specific location, for example, all of the reports can be modified. You would click the report and then you would click modify report and then you would make the modifications that you'd like to make. We do have some analysis quick reference guides that are very, very helpful when you get to that point in time, because it tells you, kind of explains all the different modifications you can make, and then also tells you how to interpret the report that is the result of those modifications. But there's always the option to export the data if you feel more comfortable generating your analysis or output reports in different programs such as Excel or SAS, for example, you can always export the data from NHSN and do it that way as well. Okay, so the next few slides highlight some resources that are important to cover. So this link here on the page shows the NHSN AUR module webpage. This is kind of your one-stop shop for everything you would need when thinking about submitting for AU, when you're in the implementation process, or when you've moved into the maintenance submission process. So I would recommend checking out that page and just kind of clicking through some of the links we have available. Under the training section, you'll see a lot of different trainings available. We have links for something very similar to what I covered today. You could learn about the AR option, or we have, I believe, 3 trainings all about the SAR. So if you're curious about the SAR, more about the statistical methods, for example, or the risk adjustment factors, I would recommend checking out those trainings. They're all about 30 minutes or less. So the SAR trainings are all about 30 minutes or less. So those are quite easy to kind of fit in your schedule here and there as time allows. The protocol link is very important. So that just contains the list of, for example, all of 91 of our drugs that we collect, all the different drugs in the SAR categories. So take a look at that protocol. The frequently asked questions, we have them available for AU as well as AR, so that's helpful. We try to include questions there that we get a lot through our NHSN mailbox from users. For data validation, we actually have 2 validation protocols available for facilities. We have one that we developed for facilities undergoing implementation of the AU option, so that covers various steps in the implementation process to make sure that the data that end up in NHSN are both accurate and complete. And then we have a data validation protocol for what we call use on an annual basis. So once you've implemented and you're kind of just reporting your monthly data going with the flow, we have a validation protocol that can be used on an annual basis. Or also if you have extremely high or extremely low SAR values and you want to do a little bit more investigation in that, that validation protocol can be helpful there. Under the supporting material tab, there's a lot of different resources that are available, one of which is our AU case examples, which I'm going to talk about on the next slide. And then finally on the analysis resources tab, that's where you'll find all of our quick reference guides. So those are 3 to 4 page documents that walk through each of the analysis report types, so you get a better sense of what's available to you and how to make some of those modifications. And then the very last red arrow on the bottom of the screen that points right to the CDA icon, that will take you to the CDA page. If you're interested in learning a little bit more about CDA or just kind of feel like you need a little bit more information before you go talk to someone at your facility about finding a vendor to do this for you, that's a great place to start. A lot of the information on that page is going to be quite technical. It's meant mainly for vendors, but on the getting started or the FAQ pages, that can be helpful for you to kind of get a better sense of CDA itself. So the AU option case examples are one super great resource that I did want to point out for you. I have the direct link on this slide, but you can get there from the NHSN AUR module homepage as well under supporting materials. But these examples, we have 3 examples so far. We're working on a 4th example right now. Provide the real world uses of AU data from facilities and systems that are using or that have submitted AU data and then have used that data in some way at their facility or system. So we're trying to get some examples that highlight a variety of settings and interventions. So right now we have one available for a VA hospital, critical access hospital, and a community hospital. The one we're working on is in a larger teaching hospital. So all 3 of them use different interventions, which is super interesting to see how the AU data are being used in the real world. So these can be used by your facility maybe as leverage when you're, pitching this to your C-suite, for example. You can say, like, see, these are the types of things that we could do with these data if they were available to us. Or if you're trying to come up with what to do with these data now that you have them in NHSN, these are kind of helpful examples of what to do with them. So we hope to continue to provide examples on this webpage, but we have 3 available here, so I'd highly encourage you to check those out. Okay, and then just the direct links to some of the things we've already talked about, the AUR module protocol, the quick reference guides, and the CDA submission support portal. Again, these links are all on the main AUR webpage, but if you wanted to get right there, you can use the links on this slide. Okay, so that's all I have for today. I did want to point out that I'm happy to take questions today, but if you think of anything after our session closes today, you can always reach out to us with the NHSN Help Desk if you have protocol or submission questions. That email address is just nhsn@cdc.gov. Or if you are in the implementation process or have questions about CDA more specifically, you can send those types of technical related questions to the NHSN CDA@cdc.gov mailbox. So with that, I will stop talking and open it up for questions. And Jackie, I'm not sure how you